once I start. So you guys, obviously, if you see any really good questions along the way, please just let me know to stop, and I'm happy to pause where I'm at and discuss it. Otherwise, it sounds like we'll talk and try to answer all of the questions you may have along the course of the presentation towards the end. So if you can hold your questions, just, keep them in the chat or keep them written down on the side, and then we'll just rapid fire any questions I can answer at the end. But again, if there's something that is burning that you must ask, just go ahead and shoot it and just stop me as I'm talking. So I'm going to pull up my presentation. Okay. Can you guys see my presentation here?
Yeah, you're good.
Okay. So hi, guys. This presentation we're going to go into today is specifically about my role as a physician assistant. And as far as I'm concerned, it sounds like a lot of you are still trying to figure out kind of where you may want to find yourself in the future, whether that is, it sounds like you're all very interested in healthcare, but maybe you're not 100% certain what else is out there besides, MD and nurse track, which are the most common things that are known. I'm here today to just talk about what it means to be a physician assistant, and then also more specific to me, what it means to be an ICU critical care physician assistant, who's even a little bit more niche because I also am a locum tenens traveling physician assistant, which we'll get into all these details along the way. We'll touch on what it looks like to go to school as a PA, what the requirements are, what you can do as a physician assistant, where we're at, and what my job looks like. So that hopefully you get, by the end of this presentation, a little bit of a peek into what the life would be like if you were to say, I would like to be a PA. So who am I? This is me. I'm Alexis. I'm a physician assistant, and I've been working in critical care now for 8 years. I started in Iowa. I grew up in the Midwest, and I got my bachelor's 4-year degree in a human health and physiology background. So it's basically an anatomy and physiology degree. I, like maybe many of you, was not 100% certain exactly what I wanted to do, but I was starting from the very beginning in a pre-med track. I thought for sure I wanted to be a doctor, but after about 3 years of undergrad, I thought, man, I don't know if I can do this for another, 4 to 8 years of my life before I can even work. So I checked out everything. I mean, I looked into veterinary science, I looked into dental work, and ultimately, kind of just luck of the draw, a family friend of mine was a cardiothoracic physician assistant. He let me kind of shadow with him inside the hospital and outside the hospital, and I saw really what the breadth and the availability was as a physician assistant. And so I was hooked, and my senior year of college applied to PA school. And then ultimately I did get in, luckily, and I then pursued my master's in physician assistant studies. And that's typically what it's called. So it's a master's degree. So I graduated and I moved. If any of you are familiar with the Midwest, I basically moved from Hy-Vee's to Publix. So now I live in Florida and I just was tired of the winter. So this is where I am now. And again, that brings me back to, I've been working for 8 years in critical care. My very first job as a physician assistant, I actually did work outpatient in a clinic in like an internal medicine, kind of what you imagine when you see your family practice doctor or nurse practitioner or PA once a year for a physical. I kind of worked in that space for 1 year. I always wanted to work in the hospital, but nobody would quite hire me right away because I was brand new with no experience. So after my first year, I kind of knew people who knew people, and I got an interview in a trauma ICU and got hired, which was amazing. And so my first several years, I started working in the trauma critical care space. We were lumped in with the neurosurgical ICU because anytime you are working in a trauma setting, you're getting a lot of, car accidents and things like that. You get a lot of head injuries. So we were all within the scope of one ICU. For those of you out there who have never set foot in an ICU, which I hope it's all of you, or have very minimal experience of what it looks like inside of an ICU, they're all very unique and specified to the populations that they treat in most large settings. There are smaller hospitals where there's just one ICU and kind of everything goes there. They may not have a trauma center, so they may not receive trauma injured patients. But in a typical, somewhat middle-sized to large educational institution, all of the ICUs are separated and designated to their specific populations. So I myself started working in a trauma ICU setting. There's other PAs out there that will only ever work in a trauma ICU, and they'll never cross paths and go to the medical ICU or the cardiac ICU. I'm kind of a little bit of a unique person where I started there and then I left the trauma ICU and transitioned into the medical ICU, where you're going from different populations of in the trauma ICU, you're seeing motor vehicle crashes, car accidents, falls, stabbing, shootings, all those types of injury patterns, as well as surgical patients who are there for some type of surgery. Post-operatively, they were sick, into working in the medical ICU, where you're dealing more with, people that are in some type of septic shock from some type of infection, whether that's like a pneumonia or a bloodstream infection, or they're there for some type of viral infection that they've had that's made them very sick, or they have sickle cell, or they have pancreatitis, or some type of diabetic emergency. Anything that is strictly medical based and not based on a surgery or an injury will fall into the medical ICU. And then outside of the medical ICU, there's the cardiac ICU that I started working at most recently in the last couple of years, where basically the cardiac ICU is exactly what you'd expect that to be. It's any patients that are dealing with any type of direct heart pathology, whether that is they're there for open heart surgery, like the cardiothoracic PA that I first followed, where they're actually opening their chest and they're needing to bypass different vessels that have become occluded, that are no longer getting blood flow. They obviously are in the cardiac ICU, have a lot of patients that have valvular problems with different valves in their heart that have to be repaired. And then basically anything within the actual chest itself, the thoracic cavity. All of those things are dealt with very specifically in the cardiac ICU. They have some of their very own mechanical support, things that you may have heard of, like ECMO, Impella's balloon pumps. Maybe you've never heard of those things, but those are all machines that help support the heart that you would pretty much almost never see in any of these other ICUs. They're pretty exclusive to the cardiac ICU. And these are just some very off the cuff examples of how each of these ICUs are very different. And there are some PAs or nurse practitioners who work only in each one and would never go to the others. But you certainly will find others that are cross-trained and work within them all, because there's certainly a lot of overlap. Then to add another piece of kind of complicated confusion, I specifically also now am functioning and have been functioning for the last 2.5 years as a full-time locum tenens critical care physician assistant. And really what that means is I put out here the Latin term for locum tenens means to hold the place of, which basically means if there's any situation where a hospital, an ICU has lost a PA or nurse practitioner, they lost their staff rather suddenly, or they know they're going to be expanding into a much bigger setting and they rapidly need to hire new PAs in order to help manage their increasing patient population, they hire someone as a locum tenens contracted work. Basically, I interview with them, they interview with me. We say, do you have the experience necessary to work in this ICU, and get started right away, so that I'm able to kind of step into their ICU after maybe 1 day of training, and kind of function as a full-time physician assistant with them for a period of, sometimes it's 3, 6, 9 months. I still have some contracts I've been working at for over 2 years, and that's just related to they've had somebody get hired, had somebody quit, had somebody get hired, had somebody quit. Because there's so much of that out there, critical care is a pretty high stress, busy type of atmosphere. There's a lot of turnover, unfortunately, in a lot of different places. But for me, that's allowed me to travel to many different states, many different cities amongst my own state, and to experience a variety of different hospital settings, a variety of different ICUs, seeing how things are done differently, and seeing unique things that are done in very high level educational institutions, as well as very rural, middle of nowhere hospitals. So I've kind of been everywhere. I've seen a variety of things, things that are done very similarly across the board and things that are done very differently in different ICUs and different hospitals in different states. So that's kind of where I'm at. And so let's kind of step back and what is a physician assistant? And a little bit of a kind of side point to you may see some states are starting to change the name to physician associate. I don't really have any inserts or personal opinions on a name change, but basically the acronym PA stands for both physician assistant and physician associate. And what exactly a physician assistant is we're an independent clinician at this point who's functioning underneath a supervising physician. So you always have your attending physician who's arguably overseeing everything you do, but they may not be there on site with you while you're performing what you're performing independently. There's a variety of PA jobs out there where you may be sitting next to your attending physician at all times and doing everything with them, but there's a lot of jobs, and I would say the majority, where you're functioning to kind of see your own patients. You're managing your own patients and you're kind of running your plans by your physician, whether that's once a day or throughout the day. A lot of it varies based off of your comfort, off their comfort, off your trust level, off of your experience. To give you a little bit of a background in my personal job day to day will be on the next slide so that you can kind of see what it looks like for me. But in general, physician assistants are out there in the world working as family practice PAs or in the ICU to diagnose illnesses for patients. They're developing the treatment plans and the strategies, prescribing medications. You're also ordering and prescribing labs and imaging. You're interpreting some of those labs and imaging. And I just kind of picked some pictures from, a couple of years of me working in trauma. And I'm so sorry if some of this is a little bit gory. Hopefully, I should have preemptively told you guys that there would be some gory pictures on this slide particularly. But if this is too much for you, you should not go into trauma surgery or critical care. But some of the bread and butter stuff that we're working with, like here's a CT scan. If you've never seen a CT scan before, this was an unfortunate thoracic spine fracture that I have to imagine did result in paraplegia. But these are the kinds of things that we'll see in a trauma setting, like a motorcycle or a motor vehicle crash, and then a very, very broken open ankle. This was a laceration that I think I should have included the post repair because this was one that I had to repair with multiple different layers of stitch recovery. But the type of lacerations you're seeing and having to fix, we obviously a broken knee bone in the left corner here. This is the distal femur into somebody's knee that was just destroyed. This is a brain bleed. If you've never seen a subdural hemorrhage, this is along the subdural or the dural layer where there's blood, that bright white, that's unfortunately pushing the brain over. You should have two of those little ventricles, those little teardrop dark colored fluid collections, but this one unfortunately only has one. So this is typically a surgical emergency, a neurosurgical emergency where they need to somehow either take the skull cap off or put a little hole in there and drain this blood out so that your brain can re-expand or that can become a very dangerous situation. This is a skull that was pretty injured in an accident. And then here, this is a gunshot wound to somebody's arm where you can actually see the bullet there shattered their arm a little bit. And then this is a bedside XLAP. This is something that we do in the ICU, unfortunately, when somebody's too sick to make it to the operating room, where we felt the need that they had to have an emergent decompression. I think we were concerned there was some type of dying or ischemic gut or bowel. It's actually a very healthy looking bowel, so we lucked out, it looks like there. And this is kind of what you look like going into and out of the trauma bay and working with all these patients throughout the day as a physician assistant. So this is what it's like. So furthermore, what is a PA? Outside of me working in critical care, PAs function in pretty much every specialty. I couldn't think of one where I didn't know somebody working in that specialty already. I have friends that I picked a lot of different examples here that work as dermatology PAs. That's becoming a very popular area of medicine. In the ER, there's PAs functioning independently and seeing their own patients. Obviously, in family practice here, that is really what physician assistants were trained and are trained to do, and kind of go from there, because that's where we have a very large lacking of support in healthcare in the United States. But of course, in the operative suite, I have physician assistant friends that work in all different aspects of surgery care, whether that's orthopedic surgery, neurosurgery, vascular surgery, kind of any specialty you can imagine. There are PAs in the operating suite, outside of the operating room, in the clinic, kind of everywhere. This is psychiatry. There's certainly a huge growing population as well for psychiatry PAs and nurse practitioners. And then OB-GYN. OB-GYN used to be almost strictly kind of nurse practitioner preferred, but it's certainly a growing space where I now know PAs who work in OB and GYN settings. So basically, PAs are working everywhere you can imagine that is healthcare, whether that's inside the hospital in an inpatient setting or an outpatient clinic. The scope of practice typically is including whatever you're attending and your hospital or clinic is comfortable with you doing, that you're also comfortable with learning and can demonstrate the aptitude to do. And then ultimately whatever they will train and credential you for. You can practice to the highest scope of your ability if you're interested, or you can practice quite dependently with your attending physician or other clinical staff. So again, kind of going into a day-to-day practice of an ICU physician assistant. What are my necessities and what are my tasks throughout the day that I am responsible for as a physician assistant, but specifically working in an ICU? So kind of some of these are just repeating to you. Something that I do all day long is I order and interpret labs and imaging for my patients, depending on what's going on with them and what we need to investigate. We round on all of our patients throughout the ICU so that we physically are seeing all of them as a group, which we'll get into in another slide. I myself will go see new patients that are coming and being admitted through the emergency department, or on the medical floor that are getting sicker and need to be upgraded to the ICU. Sometimes that's my responsibility to go physically assess them, see what's going on, order the appropriate tests, put their admission orders in, and write their whole history and physical note to bring them to the ICU so that we can start our plan of care. Something we also do as physician assistants very commonly is we're writing everybody's daily progress note in the ICU, which is ultimately a note that's going over our plans for the day and what our next steps are for each patient in the ICU. And then, of course, there's tons of procedures in the ICU, which is very unique to the ICU. A lot of the clinic work outside of the ICU, outside of the hospital, are a little bit less procedure based, a little bit more, prescribing based and note writing based. And it's completely up to you what you would be most interested in doing. But myself and a lot of people who work critical care, we like a little bit more of that hands-on. We like some procedures. And so we do a lot of things at the bedside. And some of those things, which before I go into them, if you've never seen, this is a pulmonary embolism. Here, this dark clot in this person's pulmonary vein on a CT scan. This is what a ventilator looks like, a very common ventilator. That's why that's there. This was somebody who had a very large collection of fluid in their lung, that dark area there. This little white thing, it's like the jellyfish sign. You can see the lung just floating around in this amount of fluid. So I drained it, and that's what came out. Looks like pee. This is a blood gas. If you've never heard of a blood gas, this is what we're using to help adjust this ventilator to know what the oxygen level and the carbon dioxide level are within somebody's blood. This is this chest x-ray that you could argue correlates with this bedside ultrasound to see that there's a massive amount of fluid around this lung, this white, that shouldn't be there. It should look a little bit more like this lung. And then this is just epi and atropine that we use all the time in code situations. So let's talk about some of the procedures that I do. So as a physician assistant or a nurse practitioner in the ICU, one of your very most common bread and butter procedures is called a central line or a dialysis catheter. A lot of people haven't heard about these particularly, but you may be more familiar with the term PICC line. PICC lines are placed typically by just PICC nurses. Those are a little bit less invasive because you're going through the arm, through the basilic or the cephalic vein, but the same thing, it courses up through there and ultimately is dropping off right next to the right side of your heart so that you can use medications that we call them vasopressors that increase your blood pressure or a lot of other type of antibiotics and things that are not really safe to be delivered through a little peripheral vein. One of those procedures beyond a PICC line is called a central line. It's very similar to a PICC line, but instead of being inserted in the arm, it's inserted into the internal jugular vein here. It sounds really complicated, but it's pretty simple. All you're doing is you're taking this really scary big needle and you're inserting it under ultrasound guidance. This is a linear probe on an ultrasound, and this is your best friend in the ICU because all of your procedures are really ultrasound based. And you're going to identify what their internal jugular vein is, and you're going to stick this needle in there until you get blood, and then you feed a wire in there. You take the needle out and then you advance a catheter over that wire. So the wire is your guide. And then you remove the wire and now you have a super long 16 centimeter to 20 centimeter IV, basically, that delivers medications right to your heart. So that's one of the procedures you're doing, almost every day in a busy ICU. As well as something called arterial lines. This is another everyday procedure, if not multiple times a day, where you're placing something into somebody's artery. It's very similar to an IV, only instead of going into the little veins in your wrist, you're going into the artery. And the reason that you would place this is so that you can actively see somebody's blood pressure second by second. The way that it works is you actually connect this catheter that is in the artery to a pressure bag full of fluid, and it measures with each heartbeat coming back from your radial artery the amount of fluid pressure that is displaced, and then is able to calculate and show you an actual blood pressure rhythm. So if you ever see this on like a movie or in the ICU itself, where you see like an actual what appears to be heartbeat rhythm on the monitor that's giving you a blood pressure, that's an arterial line. And what we're using that for is for patients that are critically ill. Commonly, they're on these vasopressors that are augmenting their blood pressure because their blood pressure is otherwise so low that it would not be able to sustain them. And so that we can adjust those medications in the moment, second by second. And we don't have time to wait for a blood pressure cuff to go off every 5 to 10 minutes because you could miss somebody's blood pressure dropping very quickly. So that's the function of an arterial line. And this is the setup. I took a picture of what the setup looks like for an arterial line, but really it's just this here. This catheter here is the arrow dart, and just the tip of it is what is going inside of somebody's radial artery there. So that's something you do every day. And then also chest tubes and thoracentesis. I kind of alluded on the prior slide of an area of fluid that needed to be drained. A lot of the times we have accumulations of fluid, whether that's from an infection or a cancer or just irritation after a heart surgery, into the chest wall and around the lungs. Those are things where we put in a chest tube or we just stick a pigtail catheter in temporarily to drain the fluid and then pull the pigtail right out. That's called a thoracentesis. Chest tubes are typically the larger bore chest tubes like you would see here. This is a great x-ray to demonstrate a pneumothorax, which what a pneumothorax is it's a collection of air where the lung was actually punctured or damaged somehow and started draining out air. And so this one does a really good job of, this is the actual lung edge here. You're looking at the same picture here where you can see this is the edge of the lung. So it's basically a baby looking lung in there. And what happens is the air leaks out into the chest wall and has nowhere to go. So it compresses the lung so that the lung gets smaller and smaller as it's leaking air out, to where suddenly this patient can no longer breathe. They develop respiratory distress and potentially respiratory failure. And so this can become an emergency where you need to recognize what's going on and what is needed to fix that. which is a chest tube or any type of catheter that you are ultimately sticking between the ribs and draining this air out into this type of collection system. This is a pleurovac where it's either going to drain air, fluid, or blood. But the intention is the same. The process is the same. And functionally, you're waiting then for when you drain this air, the lung is then able to re-expand and the patient does better. And once that happens, you pull the tube out. So it's
Hey,
magic.
Alexis, really
Yeah.
quick, just for the next slide. You got a pop-up from Zoom just saying that you're sharing your screen. If you want to go back to Zoom and just hide it, um, it's just cutting off the very bottom of
Oh,
yeah,
I gotcha.
yeah,
Sorry,
it's just cutting
guys.
off the bottom of the camera. I don't think it blocked anything else, so you're totally good. I just wanted, or
Okay,
the X-ray, I just want to make sure everyone can see the X-ray.
here, I'll go through again. There you go. Does that
Yeah,
look better?
yeah, you're all good.
Okay, cool. So yeah, in general, this is something that you would do as a physician assistant or nurse practitioner throughout the medical ICU, the cardiac ICU, and the trauma surgical ICU very commonly. They all have different reasons to have fluid or blood collecting in the chest, but they all do. So this is another procedure we're doing. Another two really common procedures are intubation and bronchoscopy. So intubation is ultimately, you could even follow it on from the last slide where say that patient develops what we'd call respiratory failure, where they're not able to breathe on their own and their oxygen sats are just extremely low. They're becoming less and less aware. And suddenly that becomes an emergent situation where you may need to breathe for them. Or say there's a person who has a terrible brain injury and they're no longer aware, protecting their airway, breathing appropriately, or you're worried that they could vomit and aspirate and you need to protect their airway. Ton of different reasons why you would potentially need to intubate somebody, which means you're putting them onto a ventilator where you're going to be breathing for them. That procedure is performed either direct, like this picture here, where you're just taking this as a laryngoscope that just has a light on the end that you're sticking into somebody's trachea, looking at their epiglottis and feeding what this is here, the endotracheal tube. The endotracheal tube beyond their epiglottis and into their trachea in order to connect the top of this endotracheal tube to a ventilator to support their breathing entirely. Most commonly, though, we're using something like this. We're using camera max nowadays, or they're called glide scopes most frequently, where you're physically using that, but then you're looking at a camera screen to be able to see their epiglottis in the back of their throat and then advance that endotracheal tube in beyond their airway. Again, this is something super commonly that advanced practice providers like PAs and nurse practitioners are doing in the ICU, sometimes in the ER, less frequently as far as I'm aware in the ER. And then kind of along with intubation is something called bronchoscopy. So we do this a lot of times when patients aspirate, when they vomit and a large amount of vomitus, it's obvious that they inhaled that and then developed respiratory failure and we had to intubate them. We'll go down there with this little camera that we can actually take. This is a view of the carina, which they're showing right here. It's where the trachea separates into the two bronchus. This is what that looks like. And you can maneuver the camera. It's kind of like a little video game to go right or left and go down there. And you can actually, it has suction attached to it. You can suck out whatever it is that they vomited or aspirated, or if they have like a ton of mucus from a pneumonia that needs to be cleared out and you need a sample, you go down there with this bronchoscope and you clear that out. And again, a common procedure that's done in the ICU very frequently that you would be comfortable doing. And then kind of one of the other ones, ACLS and cardioversion. This is basically ACLS, advanced cardiac life support. It's like a higher level of the basic life support where you teach regular people out there to do CPR to anybody whose heart stops. ACLS is just adding in the medications and being able to interpret the rhythms that you're evaluating while you're doing CPR on a patient. This is something, unfortunately, working in the ICU specifically, or maybe in the ER, that you would see all the time because you're dealing with critical patients who are very sick and at any time their heart could stop. So you have to be comfortable with dealing in very high stress situations and keeping things organized, because as the physician assistant, typically our role, if the attending is not present, which is very common if I'm working nights in an ICU, is basically to be an extension of your physician, where you're now the one that's leading and directing the whole group throughout the code. Your job is to be the calm, cool, collected one that says, what is our rhythm? Continue CPR, let us know when it's been 2 to 3 minutes and we can push the next epinephrine. And let's get ready for our pulse check. Let's get the patient on the monitor so that we can evaluate the rhythm is and whether or not that rhythm is shockable. You may have no familiarity with basic life support or advanced cardiac life support, but it's pretty much as simple as that. It's an algorithm that you're following, and your role is to not freak out and just make sure that you're treating things correctly as you're taught in ACLS, which is a certification that you can get that will walk you through everything and tell you exactly what you need to do in these exact scenarios. Cardioversion is kind of the sister to ACLS, where basically cardioversion is when somebody has a pulse and is awake and talking to you, but their heart goes into some type of very irregular rhythm. Here's an example of one that we would arguably call it's either AFib RVR or like SVT, where their heart rate is so fast that before long, their heart won't be able to push blood forward appropriately to keep this patient not alive, but probably awake or not in some type of shock. So you need to get them out of that rhythm. And if medications are not working to do that, you may need to shock them, which is called synchronized cardioversion, which is demonstrated very well in this photo down here, where you're delivering an electric shock that then leads this patient, hopefully, back into a regular rhythm. And this is what that looks like. This is a life pack. This is exactly kind of the machine that you're using at the bedside that this is demonstrating here. And this, unfortunately, is what it looks like writing out a code. So this is something you also see, hopefully not daily, but frequently working in any type of ICU setting. So putting that all together and kind of just going through my life, I picked trauma critical care ICU because I'm not going to go through every single one. I've done different topics, different presentations on what it's like to work in the trauma ICU, what it's like to work in the medical ICU, what it's like to work in the cardiac ICU, because they are truthfully all different. They share a lot of commonalities, but they are all their own complete presentation topic if you're interested. But truthfully, when I worked trauma critical care exclusively, my schedule was 7 days on, 7 days off. So we rotated between days and nights. So every 6th week that we were on, we would work 7 days on nights. And then you would do 2 rotations of 7 days on days. That's a pretty common structure for a lot of different ICUs, is a week on, week off. But there's so many variations as well. I've seen 5 days on, 5 days off, 3 days on, 3 days off. I've seen a variety where just all of the physician assistants make their own schedule, and as long as everything was covered, it's covered. The reason a lot of places will pressure you to do 5 or 7 days on and off is really just for the continuation of care. It's better when you know the patients really well that have been there. It's easier to follow up day to day when you already know them from the day before. So that's why you'll see that structure pretty commonly in a lot of roles, but certainly working in the ICU. This schedule is very different than any other schedule where people are working in the ER or working in an outpatient clinic where they may be working Monday through Friday, 9 to 5. This is just what my schedule has looked like. Our common cases that we would see in the trauma ICU, a lot of the times I've kind of talked about, a lot of times it's car accidents, tons and tons of car accidents, motorcycle accidents, different variety of falls, people falling, from their roof doing roof work, people falling out of trees doing tree work, falling out of anything you can imagine, unfortunately, leads to injuries. Bicycle accidents. In Florida, certainly there was a ton of horse riding injuries and golf cart injuries. And then the typical knife and gun club kind of trauma injuries, we, of course, would see those too. And then also because it's a trauma surgical unit, you got a lot of post-operative surgical cases, bowel injuries, whether that's a bowel obstruction or this leads to something called bowel ischemia, where part of your intestine actually dies because it doesn't get blood flow to it. That needs to be cut out and resected. That can make people really sick. And a lot of times they'll end up in the ICU afterwards because their blood pressure is very low and they're in some type of shock. abdominal compartment syndrome. That's kind of that picture that I had where we were emergently having to open someone's abdomen to relieve the pressure in their abdomen. Any type of mass or cancer in the abdomen that needs to be resected sometimes can result in very sick patients after surgery who end up in the ICU. Or if you needed your appendix, your gallbladder removed because you have appendicitis or cholecystitis. And a lot of the times when those are removed, you're very stable. You can go to the floor, you can go home. But if something happens that makes you very ill during that case or after that case, you'll end up in the ICU. And this would be the surgical ICU in that setting. So just some more pictures of just the life working in critical care. This is unfortunately, this was a really nasty cancer that completely eroded somebody's femoral head, which you can see should look like this, and it was gone. So that was probably the worst type of osteocancer I'd ever seen. Working with the ultrasound again, this is your best friend. You're going to do everything in the ICU with your ultrasound. Epi, that's what you're pushing during a code. This is a continuous dialysis circuit. This is something we use all the time. That's why you're placing those dialysis catheters, is so that somebody who develops an acute kidney failure, which is very common when people are very sick, they end up on this continuous dialysis. And then this is setting up for a dialysis line. It's kind of cut off. So, and then my typical day to day. So that's kind of overview of what we see. But from 7 a.m. to 7 p.m. on a day shift, what does that look like as a PA? What does my job when I walk in the doors to the hospital and I work in the ICU actually look like? Well, typically, how it starts is I show up at 7 a.m. The night team that's there will sign out to the day team, me, my attending, and anybody else who's going to be working in the ICU that day. And they're going to go through every single patient. If it's your first day on, they're going to give you a brief overview of why the patient is there, what their active issues are, any events that happened overnight, and what they need you to follow up on. If you've already been there from the day before, they'll just give you a brief overview of what happened to that patient overnight and what they still need you to follow up on. And then they're also going to go over any new patients that were admitted overnight, what they did for them, what the current issues are, who they're still waiting to hear back on in regards to maybe a consultant service, like if you needed surgery to evaluate them or you needed cardiac or cardiology to come by. Those are now going to be your tasks to follow up on for the day. After they go through all of their sign out for all of your patients, typically in a regular ICU, that's somewhere between 20 and 30 different patients. Then you have a little bit of time to pre-round where you're going to look through each of your patients' lab work, imaging, overnight events, any consultant progress notes that are recommending new things or other tests that they want done. That's your responsibility to look up on. And then you're going to round at the bedside. And that's what this picture is. This is truthfully the epitome of ICU day shift, where you really are. You're taking a computer around to each bed space for each patient. After you have physically assessed them at the bedside, you've put your hands on them and looked through, any drain that they have in them. If they're on the ventilator, what are their ventilator settings? How does their endotracheal tube look like? Everything that goes in and out of them, you're aware of. You're seeing those things and checking on those things. And then when you're at the bedside, you're presenting a head to toe plan, all the way from, what are the ventilator settings? What are we going to do to wean those ventilator settings? Are they eating? What are they eating? How do we need to advance their diet? Are they having bowel movements? What are the surgical things that we're following up on? Who are the consultants that we're waiting to hear from, or who do we need to reach out for? What labs do we need to order? What imaging do we still need to order to investigate new problems based off of their vital signs or something that's happening with the patient? And then you do this with a multidisciplinary team. You do this with the bedside nurse, the clinical pharmacist in the ICU is there, your respiratory therapy team is there, your physical therapy team normally shows up, your speech therapy team, your social work team, and the patient if they're awake, or the patient's family if they're not awake. So ultimately, this is a large period of your day. Rounding on 20 patients can take somewhere between 1 hour to 4 or 5 hours sometimes, depending on how sick and how critical they are. And then after you finish formalized rounds, you typically are breaking off. It depends on who makes up your team. I've worked in different teams where if the ICU is a little bit smaller, it may be me and the attending, and we split the ICU. I'm responsible for, these 10 patients, and they're responsible for those 10 patients. So you divide and conquer. Sometimes you work in bigger educational institutions where there's fellows that are already doctors that are preparing to be critical care doctors. You will have tons of residents from different resident services. You'll have, maybe residents from the emergency department, ER residents, or you'll have anesthesia residents, and then you all split the patient load. So then you may only have, 8 patients that you are personally responsible for. But in general, when you break off of rounds, then whoever your patients are that you're responsible for, you're following up on what you talked about in rounds. You're following up on the labs that you ordered in rounds and the images you ordered in rounds. You're calling the consultants that you talked about, wanting to discuss with. And that's your job. You're updating the patient's family with any new findings or big changes that happen throughout the evening. And this is what you do all day long until 7 p.m. The night team comes in, and then you sign out to them just like they signed out to you. You sign out all of the things that happened to your patients throughout the day, all the things that you ordered, all the things that you discovered. And then also throughout the day, if there were new admissions that you had to go see in the ER or got upgraded from the floor, those patients came to you to the ICU and you took care of them. You're signing them out to the night team and letting the night team know who they are and what they still need. That's your day to day. That's a day in the life in the ICU. So, okay, you guys maybe have a little bit of an idea of what it looks like, at least to work as an ICU physician assistant. With locums, all it is I just travel to different states and cities, and I do the same thing in every single ICU. It's pretty much the same. So what does a physician assistant degree look like? What does it look like to go to school to be a physician assistant? So as I had already mentioned, it's a master's degree program, which means it's somewhere 2 to a little bit over 2-year programs. Typically, they're broken up into 50% of didactic work and 50% of clinical work. So the first about a year, sometimes a little bit over a year, is didactic, where the structure is very intense. Everybody at most physician assistants that I know have a very similar upbringing where they call it drinking from a fire hose, because you are sitting in class from Monday through Friday for typically, 6 to 8 hours a day, just listening to lectures, taking large exams 2 to 3 times a week. You may have an anatomy exam on Monday, a physiology exam on Wednesday, and a genetics exam on Friday. And it's kind of an overwhelming year, but it's 1 year. Interdispersed throughout those didactic classwork, you'll also have anatomy labs, where this is a picture here of like a typical cadaver lab. This is how my school was. You did, dissect throughout your program different parts of the body that were supposed to correlate with what you were learning so that you could physically see, kind of what the brain looks like, what the cranial nerves look like. Sometimes it was hard to put that stuff together, but that is part of the program. Most facilities do have actual cadaver anatomy labs, but some of them are more simulated. And then throughout that, you'll also have skills labs, which I'm demonstrating up here. A lot of physician assistant schools nowadays have these very realistic sim people that, they can throw up, their heart can stop, they can have a pneumothorax. They're pretty high tech things, and you're basically practicing your skills and becoming a physician assistant in school along the way. And then the other side of after your didactics, you'd spend about a year doing clinical rotations. So these are monthly rotations. So typically you'll spend, 4 to 6 weeks on one rotation. There are core rotations for physician assistants that are pretty much standard across the board in the United States that are required for you to be able to sit for your national boards. And those are a month of surgery, of OB-GYN, family practice, psychiatry, internal medicine, emergency medicine, pediatrics, and then the remainder of the year are up to you. Those are electives that typically you can pick based off of availability and any interest that you may have. So, like for instance, ICU is not a requirement. I had done 0 ICU electives. I had no ICU experience when I took my first ICU job, and it was overwhelming for 6 months to a year to, outside of my work life, learn all of the things that were going on at the bedside. But that's what being a PA is about. You can kind of step into anything as long as you have a family of physicians and fellows and residents or whoever it is that want you there and are willing to train you and produce a critical care PA or whatever it is. So after you do these clinical rotations, ultimately you've completed the program. So you can sit for the NCCPA boards after you have successfully passed all of your classes as a physician assistant and you've obtained your master's degree and you've graduated. So then you study and you sit, and if you pass your NCCPA boards, you're officially a physician assistant. But however, to practice in any state, you do have to apply and get a state licensure. They do have slightly different requirements in every state. Most of it is just reliant on CME requirements. For instance, state of Florida you have to have like a domestic abuse and assault class that's additional that you'd have to take online to get the state license. You have to have an infectious disease certificate if you work in New York. They're just slight deviations from the general requirements that every state has, but you do have to get a license for every state that you'd like to work in. So this picture I had to include because this is how it felt in PA school, where you're kind of on your own studying and very busy for the 2 years that you're there. And I'm sure this applies to any other type of graduate program, but this is very much how we felt drinking from a fire hose. What are the requirements? What does it take to be accepted into PA school? So you do have to have a 4-year bachelor's degree. Most schools have very specific prerequisite classwork that they require. You can have any degree out there, but as long as you have also taken these kind of core classes, typically it's anatomy and physiology, microbiology and biology, chemistry and orgochemistry, some type of statistics class, psychology. You do typically have to take a medical terminology class, and a lot of them do require genetics. As far as I am aware, the typical minimal GPA is at least a 3, but the more kind of competitive PA applicants nowadays are higher than a 3.5 with a science core of greater than 3. Of course, the higher your GPA is, the more qualified you may be as a candidate. But I will say I think that PA schools are moving more and more towards the overarching person. They want someone who is human and that shows that they have an interest or a passion. And maybe your GPA is closer to that 3.5, but you're a great leader. You have amazing healthcare experience. You have a good story. You have a reason to do this, and you can demonstrate that passion in an interview. I think those things matter a lot more than people think they do nowadays in physician assistant schools and application processes. You also need to have, for most programs, 1,000 to 2,000 hours of direct patient care experience. That varies between every program as to what they will accept as patient care hours. Most of the time, it's anything that you are physically touching or interacting with the patient. I know several programs will accept scribe work. We had scribes in our ICU. A lot of them were applying for med school or physician assistant programs that accepted their job as a scribe, that they were next to us during all of the rounds and were very familiar with what we were talking about. They learned a ton. Some places don't because it's not considered you physically touching patients. But it's a variety of things. Anything that you're doing that is in a healthcare realm that could be counted towards patient care hours. A lot of the programs, if you reach out, will tell you whether or not they would accept that. Not all programs now are requiring the GRE, but a lot of programs I know still are. And what used to be required was the GRE entrance exam, which is basically in my opinion, much lower, similar to the MCAT, but not similar to the MCAT. The MCAT is much more challenging than the GRE, but the GRE is just a general exam that a variety of different master's programs will use to show that you have a score that you could be a successful student. A lot of the times they require some type of shadowing hours with a physician assistant or a nurse practitioner that at least demonstrates that you've physically seen what they do. I know sometimes that can be a little tougher to get if you don't know anybody directly, but I'm one of those people that's like, just reach out to the hospital, reach out to anybody you don't even know, email strangers that are PAs and nurse practitioners. A lot of us are very friendly and we understand, we've all been there, and are willing to help students who are very passionate about wanting to go into this type of career. You also do have to write a personal statement. I think highlight that really matters. Write your story, be inspiring to somebody who's reading through thousands of these as to why you're different, why you chose this path. And then you'll have to have a couple letters of recommendation. They don't always have to be from a physician assistant or a nurse practitioner, but somebody in the healthcare field, probably at least one, that demonstrates your clinical aptitude and why you would be a good clinician and why someone should choose you as to someone else who probably everyone who's applying are great applicants. And then kind of to pull this to a close for you guys, why did I personally become a PA? Why should you be a PA, or why should you consider it at least, or not consider it at all, but at least you could tell other people who are interested. The primary thing, and of course I'm starting it with, is flexibility. And sorry, this was my graduating class, so we were kind of a mess, you could tell, goofballs. So flexibility in all aspects. I think the reason that I was so drawn to being a physician assistant was I recognized all the cool things you can do, but that also you're not stuck in one place. I think I was scared that if I were to spend so much time and energy and money to go to a school for one thing, that what happens if 10 years down the line, I don't like doing it anymore? What if I burn out, or I just change my mind because I've never truthfully done it before? What happens then? So I was very scared to make a decision. And I think when I came across physician assistant, I recognized, wow, this is an opportunity where if I want to work in critical care for 10 years, I can do that and then know that after 10 years, if it's too stressful for me or I don't want to work nights anymore, I could work in a dermatology clinic. I could work as a family practice PA, or I could do telemedicine, or I could go into psych. You can do whatever you want. And along the way, when you are exposed to new things that you never thought you would like before, you have the opportunity to move, where truthfully, there's nothing else in medicine that can do that. There is no other role in medicine that is as flexible as a physician assistant. And it's not only about your ability to practice in a variety of different settings, but also the location. You can be a PA anywhere in the United States. You can be a PA in a very busy city. You can be a PA in a rural, middle of nowhere situation. And you can almost find any type of schedule that you want. If you want to work the Monday through Friday, 9 to 5 or 9 to 4, you can find that. If you want to work nights only because you have kids or something and you want to be at home during the day, you can find that. If you want to work 12-hour shifts or 10-hour shifts or 8-hour shifts, something out there exists for you. There's so much flexibility in all of it. And of course, you can still be independent. I love that as a PA, if you want to be, not that it's required, you certainly can still be a leader in your field. You certainly can still be training and helping with other physician assistants, with residents, working in a space where you're at the top of your own capabilities and your scope. And you can still be independent. You can make clinical decisions and truthfully take care of patients if you want to. Or you could have as much support as you want and work very minimally independently. Whatever it is that you're looking for, the availability exists. It's kind of up to you. And again, I knew I wanted to be hands-on. I knew I wanted to work in medicine. So again, being a physician assistant worked so well for me because I knew if I wanted to touch patients. I want to be there. I want to talk to people. You can do that 100% as much as you want. But if you want to be an interventional radiology PA or a surgical PA and really not talk to anybody who's awake, you could do that too. There's a lot of different variations. And because money does matter in life, wealth does matter. As a PA, I will say you can make really good money. You're making a fabulous income. You can work more if you want on the side and make excessive amounts of money. You're definitely paying a lot less for your schooling. Not that it's cheap, but you're paying a lot less than you would for a 4-year or longer program. and you're going to be out there making money right away after 2 years instead of 4, 6, 8 years. So the school time is much faster. You're out there in the world contributing to society and making your own money and leading your own life much faster. So in general, for me, PA was the best career. Anybody who asks me, do you ever regret being a physician assistant? Do you want to go back and be, a doctor or something else? I'm like, no, this is the best career. I am so lucky that I found a gem that maybe just nobody really knows about. So I know PAs are growing exponentially, and this is why. So that is it. This is my entire presentation, you guys. I appreciate all of you sitting through this long, drawn out compilation of pictures and stories, but I hope that I was able to give you a little sneak peek or a preview into what it looks like to work as a PA, specifically as a PA in a pretty high critical area in different ICUs. And I hope if you had general questions on what are PAs capable of, what does it look like to go to school to be a PA, or why would you choose to be a PA instead of something else, I hope I gave you a little bit of information on that topic. I'm very passionate about it. If you have any questions or you're curious about specifically anything, please feel free, email me. I have my email on the top. Shoot me a message on my Instagram. My Instagram is just for fun, by the way. There's really not a whole lot of education on that. It's just about funny things of critical care. But I'm here for everybody. I'm happy to do these presentations because I think a lot of people just don't fully understand what else is out there. So I'm happy to answer some questions now. Can you hear me?
Yeah, you're good. I think we have a bunch of hands raised. I've been
Okay.
looking at the
Let me
chat
pull
so
up the
far.
chat.
There was one question I wanted to tell you before you take as many hands as you can take. And that was that someone heard about another PA entrance exam called the PA CAT,
Mhm.
and was wondering if you know about it, if it like increases your chances, how it kind of affects your application.
So I'm going to be honest, I don't know as much about the PA CAT. I know that it exists. It did not exist when I was applying to PA school. And ultimately, it's another kind of prerequisite exam that I think some schools may be starting to require, but others certainly are not. If you are really serious about applying, I would just directly reach out to the programs that you are very interested in applying to and asking them if it would make you a more qualified or competitive candidate if you took the exam. Because some places, they'd be very honest with you. They would probably say, no, you don't need to take that. We don't even look at that. Or, they may say, sure, that would be great if you have a great score to send that along with your application. It may make you look more competitive. Or there are certainly, like I said, maybe some programs that are starting to require it, in which case, if that is what you're applying to, you would need to take that exam. Yeah. Looking through here too.
Cool. And then if you want to just like call on people that have their hands raised that you
Yeah.
see, and we'll go from there, and I'll keep monitoring the chat.
Okay, I'm scrolling down all the way. Let's see, I saw.
They just have their hands raised like on their
Oh, I see.
profile,
Okay.
so on
Okay.
their
Yeah.
cameras.
All right, let's start up top. I'll just go left to right. Kelly. I have Kelly.
Hi, nice to meet you. That was a really great presentation
Oh, thanks.
for sharing.
As well.
Um, my question is, what was your favorite specialty care to work in and why?
I mean, I chose to present on trauma critical care for you guys because I like trauma surgery the best. It is just crazy and not like all the other ICUs. You do see things that are new every single day, but in trauma, it's like every single second there's something crazy happening. There's procedures all over the place. People are very sick. We also were able to go to the trauma bay, and at times we would assist in the operating room. So going to the trauma bay, we would be receiving patients directly from the EMS crews that were coming in, sick. They just scraped them off the ground outside of a car accident, and they bring them to us. And we would stabilize them and take them to the CT scanner or the operating room, and then ultimately the ICU. So that was just so much fun. And when I do work trauma every single time, I'm just reminded of, oh, wow, I love trauma. I don't do it full time anymore though, because it is a high stress environment. And I don't know how I used to do it for 7 days in a row. Now, when I cover trauma, I do maybe 3 or 4 days in a row. And I'm like, okay, I need a break. But it's so fun. It's just, you can never expect or predict what your day will bring you. And I like that. So that's why.
Okay, thank you so much.
Thank you. All right. How about the other Alexis?
Um,
Oh, I think you're muted. Hold on.
oh,
There you go.
oops.
Okay. One more time.
Anyways, I also wanted to say that I also want to be a physician assistant in the future, and I was wondering if you would recommend doing nursing for your undergrad to get your clinical hours, since I know it's like 1,000 to 2,000 hours. So I was wondering how you.
Yeah, that's a great question. So I was actually just talking with a friend of mine who's a nurse practitioner about this, and not that it's wrong to go get your nursing degree, because I think that that's a completely appropriate way to do it. But most people who go get their 4-year nursing degree, it's sometimes easier to pivot from there into being a nurse practitioner, because then you can work as a nurse for, even a year nowadays, and then start applying for a nurse practitioner program, which they're slightly different from PA programs. They are a little bit more commonly online nowadays, and they're more flexible, like part-time. Most of them are part-time, where it may take a little bit longer to complete, but some of them are the same length of time as PA programs. I can't speak to nurse practitioner programs because I did not go to one, but I do know that they vary much, much more than PAs do. PA programs are a lot slightly more standardized, and they're all pretty similar, to where there's about a year of didactic and about a year of clinicals, and they're pretty much all on site and less virtual. But at that point, it just tends to be a little bit of an easier route to go that way and get your clinical hours as a nurse. But you can, as a PA, you could have any degree. You could get your degree, and on the side, while you're in college, if you're working as some type of job, what I did was I was a phlebotomist. So I worked at a plasma donation service, and we would kind of check people in, and we would take their blood and make sure that they were good donors, and then we would set them up with an IV. I also, on my summer, I got my EMT license, and I started working as an EMT a little bit. So those are the avenues that I took. But I saw a ton of people working in a variety of different settings in the hospital, whether they were working like with a lab, they were just working in the hospital to some breadth. Like I said, even scribes, like people that are working in a clinic as like a medical assistant, where they don't have to have any real long certification to do. There's so many different things that you could do. Not that nursing is wrong. You could do that. But then you would also have the opportunity to go the nurse practitioner route, is all I would say.
Hey, thank you.
Yeah, good luck. All right, let's go next. Come in. Hi,
Hello.
your name?
Thank you so much for your presentation.
Hi,
Um,
yes.
me and my family, we were like talking about becoming a PA actually, because I wanted to go into the medical field, but I wanted to be a pediatrician. And I was wondering if there was like a specific type of PA you would suggest someone would look into if they want to be a PA while going to medical school.
So you unfortunately can't do that. Or I know what you're saying, like to be a PA first and then maybe go back and go get your medical degree. Is that what you're saying?
Yeah.
Okay. So, I mean, so the PA degree, it's just a general degree. So you would go to PA school, you would graduate, you would get your license in whatever state it is that you live in, and then you'd be able to actively practice as a PA. Then if, as you were a PA, like practicing, for instance, if you wanted to be a pediatrics PA, like I know people who function in pediatrics and they're just a PA working in pediatrics, most likely you're going to see your own kiddos, like you're going to have your own patients that you see, that you split with your attending physician. And if you wanted to go back to medical school, you could certainly do that after you were PA. I would think it would be a little bit harder, just like as a PA, like being in med school and actively working, but you could do that. You could 100% be a part-time pediatrics PA and go back to med school. The only reason most people don't do it is just because of the time and effort it then would take to go back to another graduate program, but there's nothing wrong with that if that's what you wanted to do. But yes, you could 100% be an actively working PA in any realm, but certainly pediatrics, and then go back and apply for med school if you wanted to do that.
Thank you.
Yeah, of course. Good luck. Hello. Can you hear me? I think it's Beatrice. Ask to unmute. I think I clicked on the ask to unmute. Maybe not. Maybe it's not working.
I think
Let's
maybe
go
she's,
to
I think
Naya.
maybe she's frozen. Just go to the next.
Yeah.
Hi, thank you so
Hi.
much for your presentation.
Of course.
Um, I'm someone who's also interested in going into the medical school, but one thing that kind of scares me is definitely seeing all of the gore. So, how did you desensitize yourself and kind of build your tolerance, towards like the more surgical side of your job?
I think it just came with time, and while you're there, you start to see things, and then you start to see things so much that unfortunately you are kind of naturally desensitized to it. I do have a friend, one of my best friends is an OB-GYN physician, and she hates needles. And I remember I used to tease her, like, how are you going to deliver babies if you don't like the sight of needles? But it just comes down to the more of things that you're doing that are work. It's within, what you're doing to treat somebody. Suddenly some of those things become less about, the gross factor or the scary appearance, because you're looking at a person in front of you who's sick and needs your help. And sometimes it makes everything else just seem like it's not a big deal. We're here to do what we need to do to take care of this living person. And then again, unfortunately, it's just seeing more and more of it. And going through medical school, you would see all of it along the way through anatomy lab and through your clinic work. That I think it becomes more commonplace in your own brain. As much as you think it won't, it just does. And beyond that, if you know for a fact that you don't like gory things, then you could just choose an area or a specialty where you're not doing as much of that. Whether that's, as far as like psychiatry, where you would never ever see an open belly or see a wound, you would just be talking to people. There's plenty of options. If you got that far in and you realize this is just, the blood is not for me, there are different options. But if you want to get to that area, I promise you, you can get comfortable with it. It just takes time and kind of a repetitive experience.
Okay, thank you.
If I
Yeah.
can add a quick fun story, just because
Yeah.
I have one of these on this. Alexis spent a lot more time in ORs and with trauma than I have, but I've worked as an EMT and I've been in ORs before. And normally, when you're going your first time in the OR, people are quite welcoming about it and really aware. When the first time I was in an OR, I was told that as long as I faint backwards, it's okay to faint, and that like 1 in 10 people that go into ORs that are experiencing it. Like I was working with a general surgeon, so we had like full liver transplants and very
Yeah.
open stomachs.
Yeah.
And it was like as long as and then one of the other students I was working with actually did faint, but
Yeah.
he did faint backwards, so sterile field is good.
Yeah.
Everything was okay. But yeah, it's first time you're in the OR and the first few times,
Yeah.
no matter how like used to gore you are, it takes time. But
Yeah.
people are really, really okay about it, and like it takes time for everyone. So if you're
Yeah.
worried about gore, it'll be okay.
Yeah. It's okay. Same thing. I have a bunch of stories of that too. I've not fainted, but almost fainted, and a lot of people I know fainted like in school. And I've had patients faint where I made a terrible mistake where I've let somebody, their family, watch me put in a chest tube at the bedside because they were like, I want to go to med school. Can I watch you do this? I will never do that again. Because then they fainted and I was like completely sterile with holding a tube into somebody's chest. And I was like, oh my God, somebody out there, please help me. Like, please help me. Like this person fainted behind me. So, but you know, it happens. It's just, unfortunately, it's life. Everybody knows it's okay. So, all right. So, Sahar.
Hi, thank
Hi.
you for your presentation and
Of
for your
course.
time. I was wondering, for like all the specialties you worked in, what do you think was like the most challenging and why?
I think the most challenging thing is the same that would be challenging for any PA starting off. It was just starting off. I mean, whether today I were to jump into another specialty and be brand new again, being brand new in a specialty it's pretty overwhelming, especially when it's something like critical care or ER or something that has a ton of detail, a ton of work that you've never experienced before. The most challenging thing was that it came down to me to make sure that I was going to be competent and that I was going to be good at my job. Not that I wasn't surrounded by supportive and educational attendings. And I worked in a hospital that had a lot of teaching. So there was fellows and there was residents. So I had a ton of support. But of course, it still came down to me to every day when there were things that I didn't know, when they were talking about a surgical procedure that I wasn't familiar with, or I didn't understand what to the level of detail they were talking about it, or I didn't know how to wean a ventilator. I didn't know what the different settings meant, or I didn't know how to treat atrial fibrillation with rapid ventricular rate, or whatever it was. I would just write those things down. And then when I was off work, it was up to me to read about it, to listen to podcasts, to understand the area of medicine that I wanted to work in. And as a PA, that's part of the responsibility, is because you aren't taught everything as a PA. You're taught as a generalist. And then when you make the decision to go into a certain specialty, it's kind of up to you to take that specialty on to become extremely competent in your field. So that is definitely the most challenging thing, no matter where you go as a PA, is learning at the very beginning and basically being like you're back in school so that you know what you're doing.
Okay, thank you.
Of course. Kevin.
Hello, it's nice to see you. So you know how you worked in different like specialties of ICUs. So how d- so how did you adapt in to different ICU uh jobs, such as like the trauma and the clinical ICUs that you were talking about?
Yeah. Um, so there's a lot of similarity between every ICU, of course, like, ventilator structure, regular medical management, like knowing how to manage people's heart rhythms, their heart rate, how to treat sepsis and infections, how to keep their blood sugars normal, kind of all the, feeding them and advancing care, from a general perspective is the same. So there is some crossover between all of the different ICUs. So if you've worked in one, you do have a good baseline to work in another. But basically, it was just like, again, the positive to being a physician assistant is I can go anywhere as long as I can find someone who's willing to train me in this specialty in this area, and I am willing to put in the time and the effort inside and outside of work to kind of fully engross myself in that area and become a competent provider in that area. So I would just go from working in the trauma ICU to saying, I would like to work in the medical ICU now. And I applied, I got a job. They were willing to train me. And there was a lot of things that I already knew how to do from trauma. Like I already knew how to intubate. I already knew how to put chest tubes in. I already knew how to do A lines, central lines, all the procedure skills I already had, and those carried over. But then I had to learn new pathologies that I didn't know how to treat before. I had never once treated an acute stroke. I had never once treated a pancreatitis. And you learn that on the job. You're not alone in those settings where you're brand new. You're bouncing those ideas off with your attending, saying, hey, I've never had a pancreatitis patient. I'm going to go home and I'm going to read about it. I'm going to watch a lecture on that tonight. But, how do I approach this? And you do that day in and day out until suddenly now you work in a medical ICU. And these are your new skill sets. So that's kind of how it goes. But all right, how about Manuel?
Hi, I loved your presentation because I was like looking into PA, but I was just
Yeah.
wondering, During your section about like trauma and critical care, like for the common surgical cases, I noticed that a lot of them were like digestive system related or like abdominal related. Is there a specific reason for that?
No, it's just that that is kind of the general surgery bread and butter cases. When you're talking about postoperative, like heart, chest cases, those are typically going to go to the cardiac ICU. And so, like, again, I cover the cardiac ICU as well. And that's more frequently where I would see any type of like a VATS procedure where they're going in and like cleaning out the chest wall from some type of empyema or infection. If you're talking about like vascular surgical cases, like where somebody has like an occlusion in a vessel in their arm or their leg, those a lot of times will also go to the cardiothoracic unit or the medical ICU. If it's like so I've also covered in transplant units. Like if you're talking about like transplant surgeries, those very specifically are going to go to a transplant ICU. So there's a lot of subspecialties within surgery that you'll see, but you won't necessarily see them in the trauma surgical ICU. The trauma surgical ICU will be what the trauma attending surgeons are doing. And the caseload that they tend to have is abdominal cases. That's why.
Thank you so much.
Yeah, of course. Let's see. We've got Dean. Did I click it? Okay.
Hello. So I
Hi.
was just curious on what made you like, how would you compare like working in an internal medicine clinic versus working like in the various ICUs, like as you said, like the trauma ICU, the medical ICU, and like cardiac ICU, and like I guess which one do you enjoy more or prefer, or which one do you have like a better like I guess
Yeah.
takeaway from?
Yeah. I mean, I thought from the very beginning, having a little bit of a short EMS background, that I wanted to work in the ER, but nobody would hire me because I was a new graduate. And that's a common thing as a new grad. People will say, well, we want you to have 1 year of experience somewhere and then come back. So because of that, I took my internal medicine clinic job because I thought, well, okay, I'll get my year of experience and then I'll reapply somewhere and I'll get a job somewhere. And I didn't actually expect it to be trauma ICU. That's a whole funny story where I moved, I met somebody who was also a PA. She was a great friend of mine and she worked trauma critical care. And somebody quit and I basically begged her, said, please, please, please get me an interview. Your job sounds so much cooler than my job. This is what I want to do. And I got the interview and I, begged them for the job and I got the job and I never looked back. I personally like working in the hospital way more than I like working in the clinic, but that's just me. I was kind of bored doing the whole 30-minute, 15-minute clinic, seeing a patient constantly, writing their notes all day long. I like working in the hospital, being at the bedside, physically seeing people, admitting them, having kind of some stressful things that happen throughout the day that keep your day new, exciting, and interesting every single day. So, but I like working in all of the ICUs. I truthfully always gravitate towards the trauma ICU because I think it's the most exciting. But they're all interesting in their own right. So, but that's just me. So,
Thank you.
thank you. Mm-hmm. Jonica. Hi.
Hello, I liked your presentation. My question was, what's the difference between a nurse practitioner and a PA based on like the work they do in the hospital?
Yeah, so and it's kind of a tough question because to be honest, from my perspective, we're the same. I work in the ICU with nurse practitioners every day. It's a collection of us as physician assistants and nurse practitioners, and our role is exactly the same. We applied for the same job. We're interchangeable. If this nurse practitioner I work with quit, they could hire a PA to take their role, or they could hire a nurse practitioner to take my role. The difference primarily comes from the educational system and how they get to be a nurse practitioner and how we get to become a PA. Nurse practitioner training requires you to have nurse experience. So typically it's people who are working at the bedside as a nurse after they've gotten their 4-year nursing degree, who then I don't even know what their hour requirements are, but they have their own type of hour requirements to then apply to be a nurse practitioner. Similar to PAs, they're a little bit more of a flexible curriculum. A lot of the times they're set up part-time. So their programs are more, I think, appropriate for people who, already have kids, they already have a job, they can't just quit their job and be in full-time school like APA requires. They allow them to do online schooling to some extent, to set up their clinicals around their job. And it's a little bit more of a flexible program, but they do have to pick what area or specialty they want to work in. The only main difference for a nurse practitioner is if they think they want to work in critical care, then they typically are going to take like the critical care adult gerontology structure. And then they would never be able to like work psychiatry. There's like a nurse practitioner role that is OB-GYN or peds. And then there's a nurse practitioner route that's, psych, and a nurse practitioner route for family practice. It's not as specified as being an MD and going to residency for one thing. Theirs is a little bit more broad, but it's not like a PA where you can do anything. So, but very similar. We do very similar things. Mm-hmm.
Thank you.
Good question.
So this is going to be our last question before we move on to our workshop for today. But just a reminder for anyone who has questions about PA stuff or trauma ICU stuff, anything like that, that Alexis has shared her email, and we'll send it out to you guys as well. So before we do our last question, we could just get one more virtual round of applause for Alexis, and thank you so much for joining us today. And then we'll do our last question, and then we'll move on to our workshop.
Okay, sorry for everybody else who kind of ran out. But here we go. Donga, how to say your name? Donga.
Oh yeah, hello. Thank you so much for your presentation.
Hi, thank you.
I just wanted to ask what makes an excellent trauma PA beyond like just having medical knowledge?
I think it's the same thing that makes any great clinician or provider out there the best. And that, in my personal aspect now, having worked in critical care and in the hospital in general for 9 years, is A, to be humble and recognize that you don't know everything and you're going to continue to learn every single day. B, to be a great team player, because working in any aspect of healthcare is a team sport. No matter how independent or expert you are in your field, you cannot take care of a person or a human being by yourself. Recognizing that all aspects of the team matter and they're all so important together. And then I think the last and most other important thing is flexibility, specifically in critical care. What makes a great trauma critical care clinician, PA, nurse practitioner, doctor, trauma surgeon is the ability to be flexible, the ability to 1 minute be taking care of somebody's ventilator and then the next minute be opening somebody's chest. And, being able to organize those things and moving between one thing to the next constantly without being overwhelmed, without being too stressed to where you can't just break things down into little easily digestible pieces, so that you can kind of keep the constant chaos somewhat organized. And I think that goes probably for most areas of medicine, but definitely anything in the ICU. So that was my answer. Good luck to all of you. I hope you all do so well wherever it is that your pathways take you in medicine. Good luck. And there's tons of people out there like me out there that are happy to help you along the way. You'll meet them all. And I can't wait to work with you all someday. So congratulations. Thank you.
Thanks, Alexis. All participants, we're gonna take like a 2-minute break, like 10:33-ish. If you need water, if you need to use the bathroom, anything like that, go do that now. Zoe is here. She's gonna be running our workshop today. And so we'll get her set up and everything she needs. So bathroom, water, whatever you need. And we'll be back in a few minutes.
Cool. All right. Thanks, guys. I'm going to take off.
Cool. I think we're gonna get ready to get started. People should all be back if everyone's trickling in. We're super excited to have Zoe leading our workshop today. Zoe does some of the coolest things that I've ever seen, and we're so excited that she's back here today with our program for this summer. Zoe will talk about it, and she'll talk about ethics in a vast, interesting variety, but she does some really, really cool things. She was at Harvard studying bioethics, and she does some very, very cool things with looking at how things like anti-tobacco campaigns, and I believe she's also now working on some long COVID stuff, which is super, super cool. And she's going to tell us all about it.
Awesome. Thank you guys so much. It's hard to go after Alexis and her presentation, so I'll try to I'll try to, I guess, do it justice. But I'm here today to discuss ethics grand rounds with you, as well as share some of my journey and how I got here. And because I kind of want to do a poll right now. How many people have heard of the field of bioethics or maybe know some aspect of it? Yeah, go ahead and raise your hand if you. Okay, we have a couple in here. Oh, wow, more than I was expecting. Wow, okay. This is great to see. Still kind of an emerging field. So I'm going to give you guys a little bit of a background, and then we're actually going to go into a case that I'm going to have you guys work with me. And we're gonna see if we can kind of figure it out. So, with that said, let's go ahead and get started. So, some disclosures and disclaimers. I try to start all of my presentations with this. For conflicts of interest, I have no relevant conflicts of interest to disclose. And then disclaimer, all of these views are my own, not that of any of the institutions that I work with. And so I just want to make that extra clear as we move forward. And so medicine is a moral enterprise, and that's something that I remind myself on the daily. We all are going into the field of medicine most likely because we have care. We want to help others, and we kind of want to make the world a better place. And so, with that, there is some morality in this space. And this is a quote by the late Dr. Edmund Pellegrino, who I consider to be one of the founders of bioethics in the United States. He was a Catholic bioethicist, and so he was a physician as well as an ethicist, as well as a theologian. So he brought in a religious perspective. I personally am not religious, but I have learned so much from some of the religious figures in bioethics that I'm truly in awe and inspired by a lot of them. And so I think you'll see some of this spirituality coming into the way that I think through a lot of these cases. So let me just give you a little bit of background on who I am. So this is the origin story of a first-generation college graduate. So I'm the first person in my family to go to college. My mom is a secretary and my dad is an artist. They fully support me. They have no clue how I decided I wanted to go to college, let alone study at Harvard, and now apply to M.D., PhD programs this upcoming cycle. I'm also 27 years old, so I'm a little bit of a non-traditional applicant in the sense that I haven't taken a normal route to medicine. And I think you'll see as we go forward, I'm under the belief that there is no normal route towards medicine. You'll see people on TikTok, on Instagram say, oh, you need to take all of your prereqs in undergrad, then take the MCAT, then you apply to medical school, you don't take any gap years, or you do take one gap year. You're going to see everyone bring in their opinions. I don't believe that there is any real normal route in medicine. So with that said, the photo on the left you can see is circa 2004. My parents used to let me walk my dog and my cat which is kind of odd. I also was rocking bangs at that point. Clearly, I'm not rocking the bangs anymore, but I might have to go back to it because it was kind of a look. And then on the right, you can see just recently in May, I graduated from Harvard Medical School with my master's in bioethics. And we'll talk a little bit more about what the field of bioethics is and what that master's means. And it's important for me to distinguish that I have not gone to medical school yet. Although I was studying at Harvard Medical School, I was doing my master's. I have not yet completed the MD, which is the medical doctorate. And it just because I did my master's at Harvard, it does not guarantee that Harvard will let me in for their medical school for the MD program or MD PhD, which is what I'm trying to do. So I am under the assumption that my resume, although it's 2 pages long and a little bit extensive, I don't think it tells the whole story of me. So I was born in 1999, which I think is a pretty cool year. I think it's the best year. And then from there, I grew up, I rode horses. I lived kind of a normal life. I went to a public high school. And then from there, I started doing some advocacy work where I worked on youth anti-tobacco campaigns. And I had the opportunity to also work on the task force for the former First Lady of Virginia for childhood obesity prevention efforts. And one of the goals of the campaign was just to ensure that children had access to fresh, nutritious food, which Virginia housed the #1 food desert in 2012, which means that our state did not have access or did not have great access to grocery stores. A lot of people were having to rely on fast food and things like that. And that kind of piqued my interest in health in general. It was like, wow, there is so much going on in the health realm when it came to politics and when it came to socioeconomic status. And this is kind of where I think my love for bioethics started, although I didn't formally know that that was the name of all of these interests and thoughts that I was having. So I then went to the University of Virginia, which is where I did my undergraduate degree. So in the United States, you do 4 years of undergrad, and that's usually where a lot of students will do their pre-med prereqs. And so I was studying there, and that's when I first came across this term bioethics. One of my professors had just casually dropped the term, and she was like, "Oh yeah, my husband studies bioethics." And that was probably one of the most game-changing moments in my life, because that's when I started looking and exploring this field more. And so then I found out that I could minor in bioethics. So that's what I did. I started taking classes. I started trying to better understand what this space meant. And then from there, I went and started working full time. So I started working as a youth field organizer on a public health campaign where I got to focus on anti-tobacco work as well as childhood obesity prevention, which, as you guys already know, was my first kind of discovery and exploration in the health space. And then in 2022, so this was a year after I graduated undergrad, that's when I really decided I think I want to go into medicine, and I think I want to look at medicine through the bioethics lens. And so I was a little bit of a what I call a late bloomer. I didn't really know how I was going to do it, but I once I kind of put my mind towards something, I usually try to do it. So I started looking into how can I do my prereqs. So I figured out I could do a DIY post-bac, and that's where I just started taking classes at my local community college. I started shadowing. I started working part-time as a phlebotomist. I would go on the weekends and work with LabCorp. And so I would take people's blood. And then I just started doing more volunteering. I went to the transplant unit at my local hospital, and I started volunteering with the child life specialist there. And then I started seeing hospice and palliative care. I was so fascinated by aspects of death, which sounds kind of crazy, but I was just so blown away with how do you think about death? It's something that kind of scares me, but I really love trying to dissect what it means and does end of life really mean that your life ends? Should we still be respecting someone in their autonomy at the end of life? And so I just had all of these questions. So I wanted to learn more. And the best way I think to learn is to have hands-on experience, to actually be in the room where things happen. So I started volunteering. I went through training. I would sit with people as they would pass away. They would have these transitions, and just, I, I truly couldn't believe what I was seeing, and that this was happening all around me, that I previously had no clue. So from there, I I did a lot of other things. I started working at Georgetown University, so that was another job that I had, and I stayed there for a little under 2 years. And then I got a job working on one of the world's largest studies, which is a long COVID study known as the Recover Initiative. And I do that through NYU Grossman School of Medicine. So that's technically where I work now. And while I was working on this study, I was also studying part-time at Harvard Medical School. So that's how I was able to do my master's as well as work. And that's actually how I funded part of my degree. So it it's been a long journey, but I wouldn't change it for the world, because I think having all of these experiences has really shaped and informed me as a future physician and as a future clinical ethicist. So let's start. Oh, and I also want to note that it took me a long time to get through the MCAT, and I'm actually getting my score back tomorrow. So if everyone could send some positive energy into the atmosphere for me, that would be great, because the MCAT was really hard for me. It's just one of those exams that you have to do in order to apply to American medical schools, but she is not an easy one to do. So in addition to everything that I just shared, a little bit of that background and context, which hopefully hasn't put anyone to sleep yet, this is a little bit about me outside of my resume. I like to go running. I love doing media interviews. I love my dog, Jeff Gordon, who has 2 eyes in this photo, but right now he only has 1 eye because he had to have it removed after getting into a little bit of a dog fight. I'm also a horse girl. Some of my best friends are also ethicists that I got to graduate with. And then I've gotten to actually present my research around the world. So you can see me here in Saudi Arabia presenting some of my aging research, which was a really cool experience for me. So finding my way to bioethics in medicine. So clearly I have a pretty non-traditional route. I don't quite fit that pre-med mold, but I'm also going to reiterate, I don't know if this pre-med mold that we've seen online and we see kind of through those Reddit threads and TikToks and things like that is real. I think we all have really unique backgrounds and experiences that have brought us to this clinical space. And I I want to empower you all to use that to your advantage. You don't want to be a mold of someone else. You want to be your own person in this space and bring those values and experiences to your clinic, or to your operating room. And so for me, why bioethics? I love moral storytelling in medicine. I think that there is something so beautiful about bringing morality and bringing the real human aspect to medicine. And something else that I really like, I think the reason why I didn't like the MCAT is because there is black or white answers, and you have to pick one of the four ABCD answer choices. In ethics, there's no real clear answer. And I think you guys are going to see that as we go through the upcoming case. It really brings out humanism in this sterile field. And so bioethics is just a very unique culmination of ethics, medicine, policy, biotechnology, and kind of everything that you see in life. So I also wanted to highlight one of my favorite aspects of Harvard is within the medical school's library, they actually have Phineas Gage's skull in the bar, or like the rod that went through it. And so anyone that has an interest in neuroscience, hopefully you know who Phineas Gage is. But I think it's incredible. And so this was actually a text the day that I went to orientation. It was a text that I sent to my girls' group chat. And I said, guys, the library here has Phineas Gage's skull and the rod on display. And I sent them a picture. And all of my non-medical friends were like, Zoe, this is kind of weird. But I'm glad you're so excited about this. So, what is bioethics? Let's kind of get to this definition. And this is something that I highly recommend everyone try to take some notes on. Just this is what we're here for today. So, bioethics covers the ethical questions arising from life sciences, medicine, and healthcare. So that can include the actual clinical medicine that you're seeing. It can include the upcoming CRISPR-Cas9 systems that might come into play in gene editing, and currently are. It could include some of the health policies, the social determinants of health, kind of everything that you can think of that might be impacting medicine today, and healthcare as a whole. So it's an interdisciplinary field that tackles the moral implications of our scientific and medical advancements. And so the way that we look at bioethics, specifically right now, we try to take into account these 4 principles of bioethics. So that's going to be respect for autonomy, which is an individual's self-determination, informed consent, and making one's own decisions. So we really want people to have that autonomous agency to be able to decide what they want to do with their life. And so this can come from the patient perspective, this can come from the clinician's perspective, and we'll go into more examples in the next coming slides. Beneficence, so that's acting in the patient's best interest, doing good and providing benefit, and then enhancing welfare. So this is kind of the do good. Non-maleficence, a lot of you already know this as the do no harm principle. So this is minimizing risks and trying to avoid injury. The goal is to kind of make sure safety comes first. And then justice, kind of what you already probably think of when it comes to justice. It's the fairness in distribution of resources, equitable access, and trying to treat people fairly. So, exploring bioethics and clinical ethics. So, within the field of bioethics, there is a subset called clinical ethics, and that's what my focus is on. So, in the United States, as of 1992, all major hospitals that are accredited under the Joint Commission have some type of ethics team on call. So, these ethics teams are going to look a little bit different depending on the hospital system that you're in. But most of the time, there is a committee that is available for any individual that's in the hospital, whether it be a patient, a clinician, a hospital administrator who has an ethical dilemma arise. They can then consult ethics, and ethics can come and help them kind of work through and provide guidance. The thing with ethics is ethics will never say you have to do it this way. Ethics is not mandating anyone to follow their guidance. It's really just there to be a supportive space for individuals that might be having some type of moral distress. And so bioethics being the ethical, social, and legal issues arising from medicine, life sciences, and biotech, like we've talked about. But clinical ethics being more of that neutral player. They're going to provide those recommendations and guidance, but they are not going to be playing God. I want this to be incredibly clear. I don't like it when ethicists are seen as like these moral authorities. Guys, I can promise you I am not more moral than any of y'all. My mom can tell you stories of me being bad as a teenager. So I definitely I'm not this like better than anyone type of person. I am someone that is able to provide recommendations through an ethical analysis. And some of that has come from my training, some of that has come from my own experiences, and just being able to work through some of these cases. And so, how does it fit into medicine and public health? I think that there is a lot of overlap of medicine, morality, and human flourishing, which is kind of the goal of all of these spaces. The goal is to improve health outcomes so people can live quality lives. And the quality is going to be, again, experience from your own values and your own interpretation of that. But that's just something that we want to consider as we are all moving forward as future clinicians. So this is kind of the first case that I want to talk with you guys through. This is something in decision making. And so a lot of us are having to talk through, what would we do in this scenario? What would you do if you were given a odds ratio? So let's say you have a 1 in 40% chance of your child having Down syndrome. What do you do with that number? Is that a strong enough number for you to continue the pregnancy? Would Down syndrome at all affect your decision making and having a child? Who should be making these decisions? And so this is a case for the ethics of prenatal genetic testing, which is the testing of a fetus as it is developing in utero. And so some of these questions come to play as we are looking at some of the new policies in the United States. So if you are in a state where maybe abortion care is not legal or accessible, how do you tell your patient, hey, there is a 50% chance that your future child, your fetus at this moment, is going to have a fatal terminal illness, and we are not able to mitigate that without terminating the pregnancy, or there's no other options for us in helping. You can deliver the child, but it's most likely only going to last 1 day. Is that something that you want to discuss with your patient, being the mother and the father? Or is that something that you are, maybe you're starting to feel distress about even bringing it up? Would you ask that your patient not get genetic testing? And so this is something that I bring up because none of us know in these moments what we are going to do, whether we are the clinician, whether we are the patient, the individual who is going through this. So many of these decisions are so contextual and so personal. And in the case of pregnancy, you can see on the screen, you're making these decisions under such time pressure, and it's something that is so precious to you. That is your child. That is the person that you were trying to bring into the world. And maybe you have prayed and wished for that child to come into this space. And now you're faced with all of these numbers. And what do they mean? And is having that information better, or does it actually cause more distress for you? Whether you are, again, the patient, let's say the father, or are you the clinical team who's having to present this information? So these are things that I think a lot of us ought to consider as we are going into this clinical space. And something that I also wanted to bring up is this second line. Imagine a 1 in 40 chance of winning the lottery. That sounds pretty promising. But imagine you're boarding a flight knowing that there's a 1 in 40 chance that the plane will crash. Does that seem like a high enough risk to maybe get off the plane? And so these are things that the numbers, it's the same odds ratio there, right? And it's something that, again, has that contextual aspect to it, that until you have all of the information, I don't know if you can make a really solid and informed decision. And so that brings us into today's case. And so before we start going through, you can see these big red letters saying confidential. It's really important as you continue to move forward in medicine to recognize that all of your patients are humans. They are real living beings, and we need to be able to respect their privacy. So you may hear in Instagram or TikTok a doctor talking about a case, I can almost guarantee you that that doctor has withdrawn and withheld certain information, like, or they've completely faked some of the numbers or the diagnoses, just so they can respect that patient who they're talking about in the case, because that's really important. You don't ever want to give out someone's information without them knowing or without their consent. So today's case, the case of Elena Vela, and this is what I consider to be an autonomy versus paternalism case. And so the patient, being Elena Vela, a 42-year-old brilliant corporate attorney, she is admitted to the surgical oncology unit for an exploratory laparoscopy to evaluate a localized suspected pelvic mass. The agreement during the preoperative informed consent discussion, Ms. Vela is highly specific with her surgical team. She signs the consent form for the exploratory procedure and explicit removal of the localized mass. But she verbally and explicitly states, under no circumstances do I consent to a total hysterectomy or the removal of any other organs today. If you find anything more extensive, wake me up first. I want to weigh my options and determine what happens next. The event, Ms. Vela is under general anesthesia. The surgical team discovers that the mass is malignant and far more invasive than imaging showed. The attending surgeon realizes that leaving the surrounding tissues intact will guarantee the cancer spreads rapidly, requiring a highly complicated second surgery later. Believing it is in her absolute best medical interest and wanting to save her from a secondary major operation, the surgeon decides to perform an extended radical resection while she is already on the table. So, this is our case. How would you all approach it? It looks like Ellie.
I feel like that's like kind of non-ethical. Like, the doctor thought it was the best choice for in their like medical experience. However, that's not what the patient wanted at all. Like, and there was no like agreement that that was allowed.
Yeah, definitely a great overview there. Let's go on to Kelly.
I think like the surgeons should take into account like post like procedure as well. Like if they did went through with like the removal of like an organ or a hysterectomy, like it can also like affect like the patient's like life in other aspects, other than like their physical aspect, possibly like their relationship or like just their overall like mental health. So they also have to take into account that.
Yeah, definitely. And I think I don't know if this is what you were hinting at, but could there be a potential that maybe Miss Vela wanted to have kids in the future and now she's not going to have the opportunity?
Yes.
Jonathan.
Um, I think in the aspect of that the patient clearly stated that they don't consent, I think it was very unethical, but I think in the case this was like a highly critical situation, I think maybe the doctor would have had a bit more justification in taking immediate action. But I don't think this was that kind of situation. So I think this was unethical. But like I'm just saying like as an add-on, if this was like a life-threatening situation like, in the immediate moment, I think the doctor should have been would have been allowed a bit more leeway in that aspect.
Yeah, that makes sense. And I think one thing that I thought about when I first saw this type of case was, why did they bring up that she's a brilliant corporate attorney? And did anyone else like have that? And I don't know why that was the first thing that I picked up on, but I was a little bit thrown off by it because I was also thinking, would we have treated this individual different if they were unhoused or if they maybe didn't have a job or they weren't brilliant? Does anyone have any thoughts on that? Liliana, you can also bring up other stuff too. You don't have to answer that specific.
Yeah, I think that because she was the corporate attorney, they were probably more um hesitant. I think people who are aware of their rights are kind of posed as a threat to some physicians because they don't want to have that like lawsuit, like that potential lawsuit, if because that person knows what's wrong, knows that there was a violation. But if it's someone who doesn't know their rights, they probably are more like willing to do whatever they want, you know?
Yeah, no, I think you're right. And I think there's also this aspect of she verbally and explicitly stated that she did not want any type of additional removal of other organs, hysterectomy. And I don't know about y'all, but I don't know if I would have been aware enough to make that statement ahead of surgery. I think I would have been like, ah, yeah, okay, I'm ready. You know, when they come in and check in on you. I would have been nervous. I would have been a little bit, and maybe that's me being a little bit timid in some of these spaces. Um, let's go. Okay, I'm gonna mess up some names. Fahimi, Fahimy.
Hello, can you hear me?
Yep.
Yeah, it's sad, unfortunately, in the medical field. If you go to the hospital, they assume like you don't know the medical terms, they'll treat you differently. They will provide you with certain information that you don't require if they don't. That's why it's very important to advocate for yourself. And that's why it's always important sometimes to bring somebody that's in the health field, whether it's a nurse, a physician assistant, or doctor to advocate for you. That's why advocacy is very important because you don't know as a patient if you're under a procedure what's going to happen to you. So that's why it's it's very crucial that's why they require for you to have a sign of proxy in case that you're not able to make a productive decision, that you have somebody that's there to make that decision for you.
And I do really like that point. And I think it is incredibly important to be able to advocate for yourself. However, I am going to bring in a slight twist here. There is a certain extent to where someone outside of medicine is maybe not able to understand the expertise that a physician is able to bring. Someone who has gone to medical school, has extensive experience looking at cases and completing these types of cases. They might be looking in, let's hope the majority of physicians are looking in the best interest, the best medical interest of their patient. However, a lot of times these surgeons, these doctors who have maybe known you for a couple of hours, they don't know entirely all of your dreams and desires. So what if Miss Bela's goal in life was to be a mother? And one of the other things that I was thinking of is she's 42, so she's a little bit older. We don't know if she's had previous children. We don't know what her desire is, but what if she's spent so long being a corporate attorney and trying to get to this space in her career that she had to push back having a child? And now this is her plan and this is her goal in life. And I want to be mindful of not trying to make up like false stories about patients because we don't know this information. But these are just things that we ought to be considering and asking some of the questions as the ethicist on these teams. And so, Olivia, what are your thoughts?
I think she like since she was explicitly stating that like if you find anything more extensive, then wake me up. So she's just saying that you should wake her up. And then they didn't wake her up and they just went with it. And I think she was already like expecting if something else is there, it could be worse, but still wake her up.
Yeah. And I think that was one of the things that frustrated me a little bit about the surgeon's decision. There seems to have been the opportunity that they could have, okay, put her back post-op, and then allowed her some time to make the decision. Now, we don't have all of the clinical information, like, could this have caused more harm? And so that's where you would see some of the bioethical principles weighing. And these are questions that us as the ethicist would need to ask the clinical team, kind of get their perspective. What is the do no harm and do good happening here? So are we causing more harm if we open her up a second time? Is there a chance that that could reduce her quality of life? Could that increase infection rate? These are things that we should be considering. Manuel.
Yeah, I was just thinking like to avoid like okay, because you okay, sorry, I need to like gather my thoughts. But you were talking about how a secondary physician wouldn't really know her personally and wouldn't really want to know like her like aspirations and like her reasoning for wanting to be woken up. I was thinking she could have a secondary decision maker, like to make that decision for her, like someone that she trusts could make that decision for her if she was not able to like wake up. Because I think it would avoid that altogether.
Yeah, I think that that is a great thought to bring in because you can designate a healthcare proxy. Um, One thing that I do want to kind of complicate things a little bit, even with a healthcare proxy, a physician could override their their wishes or their ability to provide substituted judgment if they feel the case is emergent, and maybe that healthcare proxy isn't thinking in the best interest of their patient. But I think in a case like this could have helped really mitigate a lot of the issues. And so that healthcare proxy most likely would have been designated within her living will, and then a subset of the living will, which I think a lot of you might be familiar with, is called the advance directive. Um, Another thing that I wanted to bring up that might even complicate it a little bit more is this is very global dependent. So in the United States, it's a lot more normal for us to have these living wills, these advanced directives, these healthcare proxies, versus in other countries. I was actually just working in the clinical setting in Greece, and I found out that only 1% of Greeks have advanced directives or living wills. So it is something to also keep in mind depending on where you are practicing. And some of you I know will be practicing in the United States. Some of you might be practicing in other countries. And so it's really important for you to know some of like the legal landscape as well as just the ethical landscape of decision making and kind of what the flow of information looks like. So I want to make sure we have time. So let's do about one or two more. Um, what about Divya?
Hi, yes, I also agree with everyone. Like, this was definitely unethical. She explicitly like told the doctors or whoever was working, like, wake me up first. And I feel like in all case scenario, like it's always patient first. Even if like the surgeon thought it was in her best medical interest, I feel like yes, definitely should have woken up her first. And I also thought it was really interesting that they did uh describe her as brilliant corporate attorney. If I was a surgeon, I would definitely like keep that in mind and not do anything like that would bring me up in a case or a lawsuit or something like that. So I thought it was really interesting.
Yeah, no, and like I said before, I also found that very interesting. And I do wonder if even us thinking through a case like this, that would have changed how we looked at it. And I think that's where we see some of our own biases coming into play and being able the reality is all of us have biases, whether we want to admit it or not. But I think it's really important that if we can have active reflection, daily reflections on, hey, why was I thinking that? Or hey, maybe I need to take a step back and say, like, I wasn't going in the right direction there. And being able to kind of put ourselves back on the right path. It's really important in medicine because again, we are all humans, and but we're not perfect, right? And I think that's also the cool part is we're not AI chatbots. We can redirect ourselves and kind of bring out that humanity in medicine.
Zoe,
Okay.
I also just wanted to add there's one question in the chat just asking to clarify what a radical resection is. And then there's some responses to the overall prompt as well in the chat.
Incredible. Yeah, so the radical resection is going to be just an extensive removal. So in this case, it looks like the surgeon actually removed some of her reproductive organs when initially it was meant to be more of that exploratory. So the radical just being more removal than was or actual removal than was originally intended. And then I think the patient's opinion is what matters the most. So the team should wake her up first. And that was, we've gotten a couple of comments like that in the chat, which I think is great, a great perspective on kind of that respect for autonomy of the patient. Now, let's actually move to the next part of this case where we're going to see a little bit of a twist. So now you guys are starting to see what happens after. So Miss Vela is under general anesthesia. The surgical team discovers that the mass is malignant and far more invasive than imaging showed. The attending surgeon realizes that leaving the surrounding tissues intact will guarantee the cancer spreads rapidly, requiring a highly complicated second surgery. Believing it is in her absolute best medical interest, wanting to save her from a secondary major operation, the surgeon decides to perform an extended radical resection while she is already on the table. So this is where that twist comes in. The surgery is technically flawless, a medical success. The surgeon completely eradicates the cancer, and Miss Vela suffers 0 surgical complications. The ethical conflict. Upon waking up in the PACU, which is where the post-op would be happening, Miss Vela is informed of the extended procedure. Instead of being grateful, she is furious. She states that her bodily boundaries were violated without her permission, completely disregarding her career plans, personal timeline, and explicit instructions. The surgeon argues that waiting would have been medically negligent, life-threatening, and functionally a violation of their duty of beneficence. What does everyone think? Let's go with Grace.
Hi. I was thinking that I think that Miss Vela is right, is more ethically correct because she explicitly stated in her contract. And like I feel like it depends on like also how like life threatening it was. Like could it have waited a few days or like until the next time, or was it like immediately life threatening?
Yeah, and I think that's a great point. I think one thing to also note here is she verbally stated this. It doesn't seem like it was written down. But again, we also know that a lot of the procedures when you are in the hospital you're going to be signing your life away right now, right? Like they have really great legal teams who have been ensuring that physicians are protected. Because also, could you imagine being a physician or being a surgeon on this case, and you were just trying to do your job of doing no harm, helping your patient, and then this kind of type of thing comes up. So in a case like this, what should the physician had or should the surgeon have paused, had the lawyers come in, write up a contract? And that's something that also kind of complicates it a little bit. Alexander.
Yeah, I'll mention that like before like conducting a major surgery that we saw in this case, like it's imperative and it's necessary to gain the consent of the patient. This here we see that Miss Villa, she was never asked about whether she wanted to do this surgery, but the physician ultimately did it without her consent, and we can see that this was practically a clear violation of her interests.
Yeah. Talia.
I agree with your perspective, but I think one thing we didn't take into account is the surgeon's perspective, where he's again just trying to do his job. So I feel like he clearly stated that it's life-threatening and the cancer could spread, and if it spreads too much, she could die. So I think she'd much rather have him do the extended procedure rather than just having a life-threatening or potentially die.
Yeah, no, and I think that is something that we should be thinking about, right? So for the sake of time and kind of going on with this, I want to share a little bit of my perspective on this case, and then we'll break it down a little bit more. But thank you all for bringing these perspectives to light. And this is something that you all should feel empowered to be able to do when you are working as future clinicians. It's really important that you can recognize that you have a voice at the table. Sometimes you don't know all of the information, and so you also have to be mindful of that as well. But being able to be the advocate and stick up for the values that you believe in is incredibly, incredibly important in this space. And so for me, I consider myself to be a respect for autonomy girly. And I do think that that is something that has been instilled and ingrained in me as someone who grew up in the United States and kind of learning from American clinicians. I think it might have changed if I grew up in a different community or in a different country. So that's just like a global context to bring into account here. But I think this was incredibly inappropriate. I think that Ms. Vela's explicit wishes needed to be honored, and it was a blatant disrespect of her autonomy and her bodily function. Because also, even though this was medically a success and there were zero surgical complications, we don't know what the long-term consequences on her psychological trauma that this may now cause. Is she going to want to come back to the hospital? Is she now going to be fearful of surgeons and physicians as a whole? Could this then lead to more complications down the line? Is this going to send her into a deep depression because now it's just completely derailed her personal life, her career plans? And so this is something that I think is really important to consider, the longer term impacts of the initial consequence. And so this is actually a case study that I reworked based off of a real case that happened in 1914 in the United States. And so this case involved the New York Court of Appeals, and it established the right of patients to bodily autonomy. So it was written by Justice Benjamin Cardozo, and it's one of the most cited foundational legal precedents for the doctrine of informed consent in modern healthcare, specifically within the United States. So in comparing our ethics grand round case with that involved Miss Vela to the original case, the patient explicitly stated no operation, but the doctor performed a tumor removal anyway while under anesthesia for the examination. And the court ruled that performing a surgery without patient's consent constitutes medical battery. And so that's kind of where we as a society have deemed that if a patient doesn't want care and they have the capacity, so if they are cognitively able to make decisions for themselves and they refuse to receive care or treatment, or they explicitly state that they do not want care or treatment, a physician or surgeon needs to honor that case. And so in discussing this case a little bit more, I like to bring up the quote from Justice Cardoza, which I consider the Cardoza test. Every human being of adult years and sound mind has the right to determine what shall be done with his or her own body. And keep in mind, this was in 1914, so most of the time they only referred to men as being adults. And so I think one of the questions to ask in thinking about the Cardoza case is, or the Cardoza test is, did the surgeon's excellent medical outcomes justify overriding Ms. Vela's explicit boundaries? At what point, if ever, does medical emergency override a competent adult's refusal of an unconsented procedure? And that is another thing that I want to highlight here is as students and as future clinicians, it is really important that when there is a medical emergency, that if someone is not able to make decisions on their own, whether they be unconscious, or let's say they are under so much distress that they are deemed lacking capacity, it is your duty to be able to step in and help, even if they are refusing and screaming. I know a lot of you have probably watched like The Pit or Grey's Anatomy. When you see someone coming into the emergency room and they have a metal pole sticking out of their stomach and they are screaming and crying and just in so much distress, there is an expectation as a clinician to be able to help them, even if they start screaming, no, don't do this, don't touch me. There is an override that is available in these cases. But when it comes to something like the case of Miss Vela, we can see that she fully had capacity. She was not under distress in those moments. She proactively was trying to share her wishes and her values with the surgeon, and they completely disregarded them. And so reviewing the ethical conflict here, I also want to tell you guys, not every case is an ethics case, because there are some cases where we have legal precedent, we have policies in place. So it's important to be able to understand what is ethics versus what is legal versus what is just a mishandling or misunderstanding of a standard that has already been set. And so respecting autonomy, how does a patient's right to self-determination restrict a doctor's hands, even if the doctor is entirely correct about the medical prognosis? And then beneficence versus maleficence. Did the surgeon act out of beneficence, that doing good principle, or did they commit an ethical harm like battery, violation of trust by proceeding without informed consent? And then the legal and ethical bridge. Is the surgeon in Miss Vela's case is guilty of wrongdoings if the patient is now cancer-free and maybe they're living a flourishing life? But then again, we also have to think through those long-term expectations that I talked about previously with, could this cause now psychological trauma? Maybe she's physically fine, but what could the long-term burden be? And so with that said, I just want to thank you all for allowing me to be here today. I hope that this was informative, interesting, and maybe fun, and maybe even a little bit distressing. But I hope that you can kind of capture the feeling of why ethics is important in medicine. And hopefully, if this is your first time hearing of the field of bioethics, you might be a little bit excited to do more with it. But please stay in touch. Literally anything that you guys need. If you ever want to talk through ethics cases, please feel free to also follow me on Instagram or TikTok. I talk a lot about different ethics cases. There's a cool one from a couple weeks ago called Shine v. Vega that has to do with informed consent. So highly recommend watching that as well. And just please feel free to connect. Let's chat. I love setting up meetings and getting to know you all as well. So thank you. Bye.
Thank you so much, Zoe. I hope that all of you really enjoyed that. I mean, I was talking Zoe up. I think what Zoe does is like some of the coolest stuff as someone who's interested in bioethics myself, as someone who really practices something kind of similar, or like a cousin, I would say, in like trying to advance science communication and ensure that, we talked a little bit about in this case, like making sure that patients have like understanding and are able to actually understand all the medicine and the issues that they have. Like that is something that I have been getting into a lot and been TAing for and working with a professor at my university that like that's what she does is promote science communication research, which is kind of like a cousin, I think, in the bioethics because they do fit together. So we're so thankful that you're here today. Like Zoe said, please stay in touch with her, follow her. I follow her. She posts amazing stuff. Um, Ayan has updated and posted the guest speaker thank you form. So if you want to thank Zoe or Alexis or both or a dozen times, please do it. Otherwise, we're gonna wrap for today. If anyone has questions, I'll stay behind for like 5 or 10 minutes just to hang out. If anyone has stuff they want to talk about immediately. Otherwise, everyone's free to go. Attendance is all recorded for today, and stay tuned on Slack for our upcoming sessions, our next one is Wednesday morning. So thanks everyone. Thanks Zoe, and I hope everyone has a great rest.